go ahead and get started. Good morning, everyone, and welcome to our session. We have an amazing lineup this morning for a session on telehealth and PTSD, treating PTSD in the context of COVID-19. We're excited to have our panelists and have you all join us from all over the world. This session is part of a clinical learning series that we're doing on clinical innovations in telehealth from the MHTTC network, Mental Health Technology Transfer Center Network. And this series is being sponsored by 6 of our centers. This is the last of the 4 sessions. A few housekeeping items. We are really trying to make today's presentation secure. If something happens unexpectedly and we need to end today's presentation, we'll follow up with you using your registration information. That would be in the case of Zoom bombing, which of course we hope does not happen. So you know all attendees are muted and attendees cannot share video during the session. Please remember to ask questions using the Q&A feature. So we have the Q&A pod open as well as the chat pod, and folks are signing into the chat saying where they're from, which is great. You can chat amongst yourselves in that pod, but if you have a specific question for one of the presenters, please use the Q&A pod for that. After the session, you'll receive an email about how to access a certificate of attendance. We can only provide certificates for people who were logged in for at least 30 minutes. The session recording and the slide deck will be posted on our website within a few days. I know we often get lots of questions in the chat about, is this being recorded? Are we going to get access to it? And you will have access to it. You have access to all the information from the sessions in this 4-session series on the website. And near the end, we'll post the link to that. Please follow us on social media at MHTTC Network. The Mental Health Technology Transfer Center Network is a network of 13 centers, and our goal is to accelerate the adoption and implementation of mental health related evidence-based practices across the nation. So we provide free technical assistance and training, we develop resources, and we try to bring folks together across the US states and territories. You can find your regional center by going to our website, mhttcnetwork.org, and in the upper left, there'll be a Find Your Center place. So I encourage all of you to find your regional center. That's the best place to go to find information about the regional events that are being provided. Oftentimes, like this session, we also have national events and things that you can get involved with. Our website also has a searchable events calendar and a searchable products database. Disclaimer, just so everyone is clear, the views and opinions being expressed today are those of the presenters and don't reflect the official position of the Department of Health and Human Services or SAMHSA, who's our funder. At the end, we're going to ask you to do a brief survey, brief evaluation. We're funded by SAMHSA and required to submit data about the quality of the event. We really do appreciate your feedback, positive or negative. That helps us to create better trainings and policies for you in the future. So brief introduction of our excellent panel. We have 3 national experts on PTSD speaking for us today. Deborah Kaysen is a clinical psychologist and professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. Her area of specialty is both in research and clinical work in treatment of those who've experienced traumatic events, including the treatment of PTSD and related disorders across a variety of populations and settings. Dr. Kaysen is currently the president of the International Society for Traumatic Stress Studies. Shannon Wiltsey-Sturman, also a clinical psychologist and implementation researcher in the Dissemination and Training Division and an associate professor at Stanford University Department of Psychiatry and Behavioral Sciences. Her clinical work and research focus on training, implementation, and adaptation of cognitive behavioral therapies for individuals with PTSD, depression, suicidality, and anxiety. And Katie Dondenville, also a clinical psychologist, associate professor within the Psychiatry and Behavioral Sciences Department at the University of Texas Health Science Center at San Antonio. She is the director of research at the Fort Hood Strong Star Research Consortium and the program director for the Strong Star Training Initiative. I believe Deborah will be leading us off today. Thank you all for joining us, and thank you panelists for being here.
Thank you all for having us, and for all of the people who are attending, thank you for taking time out of your busy lives and days to hang out with us for a little bit and talk about how best to treat PTSD in this strange new context that we find ourselves in. So the first thing I want to point out to you is the map on the title slide. You know, COVID-19 is an unprecedented pandemic in terms of the scope and impact on all aspects of people's lives. And so trying to figure out, when is this a traumatic event? How do we proceed with treatment is a really big question that we are all sorting out, but we do have some literature to guide us. Heather, if you would go to the next slide. Brilliant. So I think one of the first questions that comes up is, when is this a stressor versus traumatic stress? And this is an issue that I've seen come up quite a bit, especially in the popular media, but even within the clinical and scientific literature. When we think about stress, stress is an uncomfortable emotional experience where we have physiological and behavioral changes. And not all stress is bad stress. Going on a trip can be a stressor. I moved and took a new job this past year. Those certainly were stressors, and they were good stressors. But bad stress, chronic persistent stress, certainly can have psychological and physical effects. And many of the types of stressors that people are experiencing with COVID-19 may fall in more of that kind of stressor bucket. Boredom, isolation, economic uncertainty, those are stressors. Now, when we talk about traumatic stress, we're talking about something that's more specific. Traumatic stress involves exposure to actual or threatened death, serious injury or sexual violence, or repeated or extreme exposure to aversive details of a traumatic event that's usually over the course of your job. So things like watching video content, unless that's part of your job, or watching the news, does not count as a traumatic stressor, but they may be stressful events for you. Okay. Now, COVID-19 also has been associated with traumatic stress. So for example, with the rates of death with COVID-19, there are people who are experiencing the sudden and unexpected death of someone they love. For individuals who are in the ICU or who are intubated, there is literature that they are at risk for PTSD following those experiences. We can think about the paramedics or mortuary workers who are having to deal with high levels or overwhelming numbers of deaths. And certainly the frontline healthcare workers who are working in very difficult environments. They may be worried about infecting their families. They may be dealing with difficult moral decisions and ethical decisions within their jobs. Those can be traumatic stressors. Now, the other piece to remember, and Heather, if you would go to the next slide, that would be brilliant, is that even for people who are affected by traumatic events, most people who are exposed to traumatic events recover naturally, even without the help of people like us or like you. Even if their initial symptoms are high, resilience is actually the norm. So when we talk about resilience, often we talk about this as something that's extraordinary, but it is what most people experience even when exposed to stressors. It's also not something that you either have or you don't. It can be learned, it can be acquired, and it doesn't mean that you're not having a hard time or that you're not distressed. It just means that you're going to be less likely to develop longer term, more chronic psychological problems down the road. And Heather, if you would go to the next slide. Lovely. So when we look at a group that is at higher risk for PTSD with COVID-19, healthcare workers are experiencing in this initial period relatively high levels of mental health symptoms. So when we look at some data from Wuhan, China, during the first few weeks after the pandemic really unfolded, when they were at the peak of their curve, what we found was about 74% reported some symptoms of PTSD, about 50% reported symptoms of depression, a little less than that reported symptoms of anxiety, and about a third reported symptoms of insomnia. And if you would go to the next slide. When we look at more moderate to severe levels of symptoms, so something that might be more in a clinical range. Oh, no, you're right. You're right. Brilliant. What we see are certainly lower numbers. So about 35% have moderate to severe symptoms of PTSD, 15% depression, 12% anxiety, and about 8% who are having symptoms of insomnia. When we look a little further down the road, about a month out, and this is in a slightly different sample, so it is a little bit of apples and oranges, we're seeing about 7% of healthcare workers, frontline healthcare workers, are experiencing PTSD. Now, next slide. Now, the other thing to think about is where someone is in terms of exposure and what type of an intervention you might use. Because it's very important to match the intervention to where the person is in terms of their psychological needs. So when we're looking at the first 24 to 72 hours after exposure, we're not going to do a trauma-focused therapy, which is what Shannon and Katie and I are going to be talking about for most of this talk. But during that initial period, you're really working on safety and stabilization. I think the other thing for all of us to remember is that during that period of time, we're not using mental health interventions, because at that point, we're not treating mental health symptoms. These are normal responses during the midst of disasters, during the midst of extreme stressors. So there you're looking at interventions like psychological first aid. Then in the first days to first few weeks after trauma, that's during that normal natural recovery phase. And so what you're doing there is secondary prevention, and you're helping build skills like increasing coping self-efficacy, helping people reach out to their social support networks. These are things that we found are associated with resilience after disasters and after other epidemics like the SARS epidemic and the Ebola outbreak. So most of our talk is actually going to be focused, and Heather, if you would hit the button for my beautiful animation, we're going to be focused on this phase, which is the post-trauma phase. That's where we have people with chronic PTSD. Now, we are going to be talking about sort of two different populations. We have people who may have new PTSD related to COVID-19, but we also have people who we have been on our wait list, people who already had PTSD who still need treatment. And we have some people who had PTSD that's now exacerbated by the current stressors. So those are the folks in that post-trauma period where we're really trying to work towards recovery. And there we're going to be looking more at trauma-focused therapies, which you're going to hear a bit about from us in a sec. Those are usually 5 to 15 sessions, and often those are delivered in specialty mental health care settings, although they don't have to be. I certainly have plenty of work delivering those using task sharing strategies or in primary care settings. Next slide. So, and Heather, you can poke it a couple of times. There we go. So for the psychotherapies, one of the questions that comes up for all of us are, do these work? And the data is actually quite clear that specific trauma-focused therapies are highly effective in treating PTSD. So you can think about looking at the large literature on these therapies and focusing on CPT, PE, and EMDR, which are the ones that are most commonly recommended across the treatment guidelines. More than half of people who experience those treatments no longer have PTSD when they finish treatment. And for the remainder, for those open circles, it's not that they haven't improved. Some of them haven't, some of them are non-responders, but some of them still have a diagnosis, but their symptoms have improved. And then if you would hit the next animation, beautiful. We also have medication options. In general, the preponderance of data is around the use of specific SSRIs. You can see that those are less effective than the psychotherapies. I'm going to tell you what CPT and PE are in a second, Brenda, I promise. But thank you for reminding me when I use acronyms. So in terms of the medications, they have what's seen as a lower but consistent effect. They tend to be slightly less effective than the psychotherapies. And they vary in terms of the treatment guidelines, whether or not they're recommended as a first-line approach, or whether the recommendation is that you try psychotherapy and only use a medication if you cannot provide psychotherapy, either due to the patient's preferences or what resources are available in your setting. Okay, and if you would go to the next slide. Beautiful. Okay, so I have to put on my ISTSS hat for a second and talk about the clinical treatment guidelines for treatment of PTSD. ISTSS is an academic and clinical organization. We did a comprehensive review of the literature around interventions and prevention programs for adults and children. I'm only going to be talking about adults today because I don't treat children and I'm not as up on the child literature. So in terms of our review, what we came up with are that therapies that have a primary component of either exposure or of cognitive restructuring are the therapies that are most effective and most consistently effective for treatment of PTSD. Now you'll notice that there are two that have little asterisks: cognitive processing therapy and prolonged exposure, which you'll hear Katie and Shannon and I talk about as CPT and PE. Those are both evidence-based manualized treatments for post-traumatic stress disorder, and both of those treatments have been examined in terms of whether we break them when we deliver the care via telehealth, and we'll be talking a little bit more about that as we go. If you're interested in all of the guidelines, you can get to those through the ISTSS website, or we can provide you with a link in the resources at the end of the talk. Next slide. So in terms of what is prolonged exposure and what is cognitive processing therapy, looking a little bit more under the hood. So for prolonged exposure, we think that the active component, the piece that makes it work, is exposure. And basically what that means is it's exposure to feared stimuli that teaches people that what they think about the event itself and what may be dangerous or not may not be entirely accurate. And prolonged exposure includes two main elements: imaginal exposure, which is exposure to the memory of the trauma itself, and then in vivo exposure, which is exposure to trauma-related cues that are safe to help bring down that fear response. Prolonged exposure is typically done in anywhere from 9 to 15 sessions, although I have some colleagues who are testing a 6-session version of prolonged exposure with very nice preliminary results. Cognitive processing therapy is a predominantly cognitive trauma-focused therapy. And the idea about that is that when we change our beliefs about the traumatic event, why it happened, who's to blame, that place where people get really hooked in the what ifs, if I had done this, maybe it wouldn't have happened, and the lessons they learned from the trauma and applied forward in their lives. If we teach people how to modify those beliefs, it brings down trauma-related symptoms. Next slide. So just briefly to show you the data, this was a trial that was completed a number of years ago now, where people who were in the original clinical trial comparing cognitive processing therapy to prolonged exposure were followed up 5 to 10 years after they had finished 6 weeks of twice-a-week therapy. What you can see is from pre to post-treatment, some really nice treatment gains. Those are basically and statistically are maintained at 3 months, 9 months, and 5 or more years following the end of treatment. So what this suggests is if we get PTSD symptoms down, they tend to not reoccur. Next slide, please. All right, and if you would click it again, beautiful. And one more time. So can we do trauma-focused treatments in a pandemic? Yeah, right, I think we don't entirely know. We have some evidence that suggests that likely we can. And I'm going to show you a little bit of data around that now, but we don't have data yet. So the one piece that we can lean on is this is from a trial that I conducted along with Judy Bast and Johns Hopkins. We provided group cognitive processing therapy in the Democratic Republic of Congo. This was delivered to sexual assault survivors. And During the trial, there was ongoing violence. We had one group where we had a group member who was murdered. We had no villages that were entirely safe. There was ongoing armed conflict throughout the study. And so what we did is we actually divided the villages into two based on the level of insecurity in those sites. And what we found is that although there was somewhat higher symptoms, although not statistically so, for higher symptoms for the groups that were in high conflict villages, what we found is that by the end of treatment, there was no difference. People improved even if they were in settings where there were current stressors and current trauma exposure. And we actually just completed a 7-year follow-up of the women from this study. And like the 5 to 10-year outcome study in the US, what we are finding are relatively low rates of relapse, even for individuals who are in ongoing conflict settings. Okay, next slide. So, I think the piece around this, and I'm going to hand this off to Shannon in a sec, is that when we're doing trauma-focused therapies delivered via telehealth, delivered via a pandemic, we need to be able to be flexible. We need to figure out how are we going to adapt these treatment manuals in ways that keep the core elements of the treatment manual intact and deliver the active ingredients in the treatment in a way that is going to be effective for the people that we are helping. And with that, I'm going to hand it off to Shannon.
Great, thanks. Can everyone hear me? Okay. So as Deborah mentioned, very often when we're delivering treatments in routine care, but especially in light of COVID, what we've learned is that we have to be flexible and we have to be able to adapt the treatment. So I'm just going to share a few different principles that we want to keep in mind. And this would apply whether you're doing, a trauma-focused CBT for kids, whether you're doing prolonged exposure, cognitive processing therapy, or any other treatment where there's sort of a set, there's a protocol and a set of things that comprise the therapy that you want to make sure you do. And one thing that I think is really important is to differentiate core elements and core functions. So when we talk about core elements of treatments, we're talking about things like the parts of the intervention that we think have the impact, that the active ingredients of the treatment. So for example, if you're doing a cognitive behavioral therapy, cognitive restructuring would be considered to be a core element. Most treatments have an element of psychoeducation to make sure that people understand what the treatment is and what the rationale is for. So we want to keep these things, these core elements or their functions intact. When we talk about core functions, what we mean is psychoeducation is the core function. We want people to understand why the trauma, why they're having the responses that they are, the trauma responses, and how the treatment can address it, what some of the principles of the treatment are. Now, you can maintain fidelity to the protocol. You can do that. You can do the psychoeducation components and achieve that function in a lot of different ways. You could use a video. Yeah, if we can back up one slide. You can use a video to do that and then have a discussion. You could use written materials. You could have a group meeting where people, where a bunch of people who are going through the treatment can kind of get the basic psychoed, as long as you're doing that key psychoeducation piece. So these are the parts of the intervention that we think are effective and necessary. And so part of what we need to do as we're, thinking about adapting is, do we think about whether, do we need to get creative about how to deliver these core features of the treatment? Can we adapt it and still meet that function, meet that key need and deliver that active, important part, but maybe sometimes a little bit differently than it says in the manual, as long as you've sort of accomplished the goal. The person understands the treatment and why it's happening. For example, it could be if people are learning to cognitive restructure, they could use worksheets. They could use like a mnemonic, like catch, check, change. But as long as they're being prompted to slow down and, you know, take a step back and look at their thoughts, then they are getting a core element. So for example, for exposure, if you're using exposure, it might be that instead of having somebody go out into places that are not actually safe because of COVID, you know, it's like going to a restaurant, you might use virtual reality to sort of, you know, have them get exposed to some aspect of it. And that might be the best we can do right now, but it might help you get part of the way there because you've delivered that kind of key feature. So if we go to the next slide, on the next slide, we're just going to kind of talk about, in theory, when you hit a roadblock and you're finding, you know, there's some aspect of this treatment that I can't quite do because, you know, everybody's kind of in their house right now, or maybe there's a literacy issue, or maybe there are constraints within the system in some way that would keep you from using the protocol exactly the way it was delivered. The more you can anticipate that, if you look at the upper right quadrant, the more you can anticipate that and figure out a way to kind of provide those key functions of the treatment, that's the sweet spot. That's where we'd want to be. So you might say, okay, we can't actually do live exposure. We could do some sort of virtual reality. We're still delivering some key element of the treatment. Let's see if that works. Or instead of written worksheets, Deborah's example in the Democratic Republic of Congo, they actually had women memorize some key questions instead of using worksheets that had those questions on them. So those were planned, fidelity, consistent interventions. Now, sometimes you get thrown a curveball. You think you're going to be able to do something and you can't. So if we move down lower right, if you have a sense of like, well, what's the key thing I'm trying to do? You know, what's the key thing that we need to be doing in this treatment right now, or what are some of the key things? And you make adjustments so that you're still adhering to those kind of core functions. You're still meeting that goal. That's what we're hoping to see, you know, when we get thrown a curveball, which we all do. Now, on the left-hand side, this is when you start moving away from the protocol. And what I would really encourage, let's say that it's just impossible. There's not a way to provide some sort of key aspect of the treatment because of system constraints. Maybe you only have, you know, 3 sessions and it's a 6-session protocol or something like that. And so you have to drop some different elements. That's where it's going to be really important to evaluate, to say, oh, wow, did we drop something we really needed? Because if we did, maybe we got to retweak if we're not getting the outcomes we would hope for. So just monitoring as you're doing that, and checking to see if you're not getting the outcomes you would hope. Do you need to kind of go back to the drawing board and rethink, okay, well, what do we do? Is there another way that we can kind of make sure that these key elements are there? And if we go to the next slide, one of the things that we think about, especially at kind of more of an organization level, if we're thinking about the need to adapt. So this could come up if you're providing treatments by telehealth. First of all, you know, some of these treatments have been delivered very successfully by telehealth. So in some contexts, you might not need a lot of adaptation other than not delivering it face-to-face in the room, and you've got to figure out ways to get materials and things back and forth, which is not insignificant, but it's not a fundamental retooling of the treatment. What we would recommend is if there is some sort of information or data that you're going to need to adapt, if you're able to pilot, that's ideal. But even if not, we recommend kind of doing some evaluation and looking closely at, you know, well, what are we seeing in terms of symptoms, in terms of functioning? Are we seeing the kinds of changes we would hope for when we make these adaptations? But as you're making them, as I sort of talked about on the previous slides, keep an eye on what the core features are. And sometimes this might be, you know, you need to go to the technical assistants, you know, and get some help there from the treatment developers around what are really the key features, so that you can really adapt with an eye towards preserving those in some way. Either way, we do recommend evaluating. And if you find that as you're evaluating, you've made some sort of an adaptation and you're not getting the outcomes you want, what we would hope for is some sort of iterative and hopefully kind of stakeholder driven. So where you're working with, you know, individuals who know the treatment well, Sometimes you might be working with patients or families to sort of, keep an eye on preferences and what's feasible, or with your leadership, and keep iterating so that you can kind of figure out how to make the tweaks that you need to make, either at your own practice level or if you're doing this more at an organization level. But keep an eye on whether or not you're getting the outcomes you want, or something that feels close enough. This will allow us to reach a lot more people. It doesn't seem like it's quite as effective, but our alternative is that way fewer people get it. So, as you're making these decisions, collecting data, checking in with your stakeholders, with the people who, can support you in providing the treatment, to make sure that you're kind of on the right track and that the adaptations are having the desired effect, is really important. And we did some work with a community mental health agency that had made some adaptations to cognitive processing therapy for their clientele, who was affected a lot by community and immigration related violence and trauma. And what we found is that fidelity, so sticking to the protocol and delivering it skillfully, was associated with symptom change. But when people made fidelity consistent adaptations, so when they made these changes that preserve the core elements of the treatment, in the context of a protocol that they were delivering, it looked like CPT, but they were making these little tweaks in these fidelity consistent adaptations. We found that more fidelity consistent adaptations was associated with greater symptom change. So there are times that you can adapt and actually have a better impact than you would have if you hadn't. But you want to do that carefully and with these core elements in mind. So I'm going to shift it over and let Katie talk specifically about providing these treatments over telehealth, and about some of the mobile and web-based sort of tools that can support the delivery of these treatments.
So prior to COVID, we had already conducted a lot of research looking at the delivery of CPT and prolonged exposure via video teleconferencing, telehealth. And thanks to the leadership with the National Center for PTSD and the VA, we have CPT and PE coach client apps that have the core content to assist with the sessions. So these are available both for Apple and Android, and are particularly helpful in the delivery of telehealth, because we can't necessarily hand you that paper client workbook, but file sharing is another option too. But these are great apps. Next slide. So one of the things that I have the privilege and pleasure of doing throughout my week as a part of the Strong Start Training Initiative is we have about 20 hours of case consultation happening with everyday providers who are implementing CPT and PE in their practice. And so one of the things that we're hearing as initially we shifted to telehealth with COVID, and as we're stabilizing and adjusting to the new normal, is that telehealth looks different than maybe we wish it would, right? The ideal situation would be the top left-hand corner, where we're sitting at our desk with our computer and our client's sitting at their desk with their computer. But many of our clients may not have the luxury of the space and privacy in a home office, and especially as we're managing shelter in place or restrictions or having challenges with childcare. And so we're seeing telehealth being delivered, video telehealth being delivered in creative locations, including the car, basements, bathrooms, as ways to have privacy and be able to still engage successfully in CPT and PE and other treatments. We're also delivering CPT and PE over the phone. So access to high-speed internet with consistent bandwidth is not always available, and that's not a rural problem. It is a rural problem, but it's also happening in our urban centers and our cities, and it may relate to many, many factors. So if you would have asked me March 1st if we can deliver CPT or PE on the phone, I would say, well, wouldn't you want to consider other alternatives? And I can tell you today that it is being delivered on the phone with success. And so we want to be flexible and engage our clients where they're at. Next slide. One thing that's particularly important when we think about exposure during a pandemic, and this applies to prolonged exposure, so thinking about in vivo exposure that are associated with prolonged exposure, but it also applies to any exposure-based treatment for all anxiety disorders. So I first want to say exposure is not a telehealth issue. We know how to help clients engage in exposure when we're delivering treatments via telehealth. But the biggest challenge that we're having is it's related to shelter in place or social distancing. And so I think there's a couple, the hierarchy in PTSD includes these 4 different categories. The way I like to think about this is there are a couple opportunities that we have in this current delivering treatment via telehealth, and there's a couple challenges with the shelter in place and social distancing. So first opportunity is that we don't always have the ability to support our clients in vivo exposure during sessions. But because we're doing video telehealth, it's possible your session could be scheduled and you could be with your client on their phone during that exposure assignment. It's an opportunity. The other opportunity is we have to think a lot about the exposure hierarchy using outdoors, using driving, and potentially using partners in engaging exposure activities. Some of the challenges is that some of the things that we would normally have our clients do for exposure. So for example, when I think about my clients, oftentimes there are exposures about being in stores with a lot of people, standing in lines. That may not be possible in the same way right now. And so we may have to plan for in the future, right, of them doing some of these exposures and thinking about what are other things that may approximate that exposure. The other thing that's really important, Shannon mentioned this earlier, I mean, we can use media, YouTube, pictures, movies, but we could also use virtual reality to augment that exposure experience. But it's a challenge, and the importance is that there's a need for a lot of repetition in these exposure activities. Next slide. Cognitive processing therapy is a treatment that's often implemented in a group setting or an intensive outpatient setting. The way in which we're delivering care now with COVID prevents us from meeting in groups in the same way, like on the picture on the left, but we are hearing very successful adaptations to deliver group therapy via platforms like this, via Zoom. And it doesn't necessarily require any change in the actual core elements of the intervention. It's just how the group is meeting. And so these have been good surprises. And I've heard from colleagues that have been conducting group IOPs via Zoom type platforms. And it's different than we might have thought about, but it is not necessarily negatively impacting the delivery of the core content, which is exciting because people need care. Next slide. The key piece is that we need to work with our clients in collaborative decision-making on what is the best treatment plan for them in the context. And so that collaborative decision-making is very important, and revisiting that is very important. So end of March, there may be some clients that are feeling like, I'll just wait until I can come back to your office. That was a good hope. And some people are meeting in their offices now, but it may not be possible for the foreseeable future. And so we need to revisit collaborative decision-making with our clients with the information that we have at the time. The other thing is that in both of these treatments, there are space to integrate COVID-19 stressors. And so we would want to, in cognitive processing therapy, look at some of the thoughts they're having about COVID-19 and potential stuck points. In prolonged exposure, we might also add COVID-19 related avoidance if it is out of proportion or causing impairment into their hierarchy of in vivo. We also want to think about offering additional support when needed. And so that may take the form of different types of reminders or a check-in call or scheduling that in vivo where you can assist in that way. The important thing is when there are detours, we want to consider the model to address the detours. And so even before COVID-19, life happens and gets in the way of structured treatments for PTSD. And so we want to think about using the skills that we are teaching our clients in either of these therapies to apply to that everyday stressor. And thinking about when are we going to get back on track, because there was some reason that you and your client decided to embark on an evidence-based treatment for PTSD. And my guess that was because this was particularly disabling and impairing for that client. And so thinking about getting back on track when we have to take those detours is really important for our clients. So thank you for this opportunity. I think we're going to shift over to questions.
Thank you very much for your presentations today and the content that you've provided. I think it's incredibly helpful for all of us as we've switched in this unprecedented time to learning how we use our talents and our skills, our knowledge and the trainings that we've done and use it in this new virtual framework. It's great to have colleagues that we can learn together with. So we're going to take some time to just address some of the questions that have come in throughout the presentation. Hopefully you can all hear me okay. This first question I think is going to be addressed to Shannon. Shannon, in one of the slides that you presented, it showed some content related to a voltage drop. Can you briefly explain to us what's meant by that, phrase or term?
Sure, yeah, and I apologize for not doing that. I think I paraphrased it, but didn't reference the term on the slide. So voltage drop is basically when you get an outcome that's, probably multiple outcomes that are less potent than you would expect. So for example, if you are using a treatment like prolonged exposure and you know that in other research and when it's been done in community settings before, that you can kind of expect to see a certain level of improvement in symptoms and in functioning, and you don't see that. You see less of a sort of powerful effect. That's kind of a voltage drop. You're not seeing the same impact. And of course, there's a lot of variability for individual clients, but if you start to see a pattern after you've made an adaptation where people just aren't doing as well as they do when you do the full protocol, or as you would expect based on what you've seen in the literature, then that gives you a signal that there might be a voltage drop, and maybe you need to go back to the drawing board and rethink the adaptation to see if you can kind of help make the treatment as potent as possible while you're adapting.
Excellent. Thank you for that description, Shannon. That was incredibly helpful. So a couple of questions have come in, and I will allow either of the three of you to answer these, and they primarily relate to training. So for folks who are looking for training or guidance, really practical guidance on how to deliver these types of interventions and deliver them in this way, do you have any further guidance on tools or resources or even non-face-to-face trainings that might be available for them?
I can start. My guess is we each have different pieces of the puzzle. So in terms of cognitive processing therapy, there are a couple of different options. First of all, There are some web-based trainings that are good primers for learning cognitive processing therapy. We will provide you guys with links to those resources, but Medical University of South Carolina has that. They also have a really good one for child treatments for TFCBT for kids. People are starting to do Zoom trainings in CPT. Katie has been a real leader in that, so I'm going to have her talk about how people could find out about those trainings, but that's really started to come out. There was also a question about prolonged exposure and how to get some support and guidance. I believe that there was a webinar done by Sheila Rausch recently on how to do prolonged exposure via telehealth, addressing some of these same kinds of issues. And so we can try and hunt down that webinar and provide that resource for you guys as well. Katie, Shannon, what else do you guys want to add?
For CPT, there's CPT for PTSD website, prolonged exposure. I would check out University of Pennsylvania, CTSA, Center for Treatment of Stress and Anxiety. That's Edna Foa's lab and center, and so they offer trainings. Online, so my group, the Strong Start Training Initiative, we have grant funds to train community providers who serve veterans, but also work with agencies individually, and have been launching Zoom trainings. We've done 3 so far in both CPT and prolonged exposure. Another group that has done online trainings for years is Center for Deployment Psychology. And so they also have low cost usually it's delivered over a 2-day training workshop in both CPT and PE.
I'll just, one thing I'll just add is that if you pursue training in some of these treatments, if you can find an opportunity to get consultation after you do the workshop, that seems to be critically important. There has been some research to suggest that if you get consultation after a workshop in CPT, your patients are likely to do about twice as well as if you don't. And it can be really helpful once if you hit a wall, if you run into something you don't quite know how to handle. So a lot of these trainings will really encourage you to seek out consultation and to try to do sort of consistent consultation with at least a couple of cases. That's what's required to get on provider rosters, but there's evidence behind it that your patients they can do well even if not. Like we saw significant reductions in symptoms, but they actually can get into kind of the range of outcomes that you see in clinical trials if you're getting consultation along the way.
Excellent. Thank you for sharing those. And I should make mention to all of our participants today that a list of the resources provided and discussed throughout this presentation will be made available along with slides and the frequently asked question document. And I see that some folks are sharing some wonderful resources as well within our chat box, and we'll continue to add those to the resources available to the group. There have been a couple of questions related to target groups. And I know you mentioned that you are adult oriented, not necessarily child focused. In terms of the treatments or topics that you've addressed today, do you happen to have any information or guidance for groups on age limits or appropriateness for these types of treatments with maybe older or transition age youth?
Yeah, there is data on use of cognitive processing therapy with adolescents. I don't know that we have a hard and fast, at this age you can do CPT and at this age you should do TFCBT. I don't know that the data is quite that nuanced from either the child or adult literature, but we are finding that the therapies are effective and are well tolerated by adolescents.
It's true with prolonged exposure. They have a separate adolescent manual to address kind of adolescent related challenges that might be different.
Great. A couple of other questions have come in about the use of tools or resources via teleconferencing. or if you can you share with us some of your insights or thoughts on how do you use like worksheets, for example, when using teleconferencing? How do you utilize some of these tools?
Wants to take it first? I think any of us can.
Yeah, I'll just mention we have a lot of providers that we've been working with who have converted to telehealth while they're doing CPT, and there can be some really nice like screen sharing with just a Word document or a Word version of the worksheet can be really great because you can fill one out with them, you can attach it and send it in the chat or get it to them in some other way. And then they've got the copy that you worked on. And if they can screen share, if they're doing theirs electronically, then you can mark it up that, a lot of the web functions have things where you can circle and draw arrows if, you need to move things around on the worksheet. So it's actually, it can be really nice. And in some ways more seamless than even doing it in person. So screen sharing can be really helpful. It's a little bit trickier over the telephone, but we have some videos out that kind of walk people through how to fill out a worksheet, so that if you're doing it on the phone with them, if they can, if you're doing treatment on the phone with them and they need some guidance and they need to sort of watch and walk through how to do a worksheet, there are little videos that they could watch on their phones if they have any access to. To be able to stream a video, basically.
Yeah, I've got a fillable PDF form for the worksheets that's also been really helpful for being able to screen share and type in somebody's responses while we're working through therapy together. So that's also been really useful for me.
Worst case scenario, if they're using the app, they can hold it up. There's my son. You can take a screenshot and then share that. So I think, when we are using video teleconferencing, there's a lot of creative solutions that can be actually more collaborative than if we were sitting kind of 6 feet away. In person, I would be doing this therapy at a small table. So the video teleconferencing is really nice.
And that actually brings up another great question, Katie, about the use of the app tool. Can you guys talk a little bit about your experience or use of the app in your treatment?
So the apps are designed for the client to host the resources to deliver the therapy. So in CPT, that includes the worksheets, that includes any readings. It also, both apps have symptom monitoring and measurement. And so in the event that you are not sending them measures, they can do that prior to session and then tell you their total score. In the PE app, you also have the ability to audio record your imaginal exposure into the app. The apps are not a login, so none of the information clients put into the app goes up to any cloud. It stays on their device, so for privacy reasons. But it can be it's a good tool without telehealth. In kind of, I have clients who forget their binders, but not one client forgets their phone. So it's a good tool in general, but it's especially helpful in the delivery of materials in this context.
Thank you for sharing that. Any other thoughts about the app before I ask the next question? We might have time for one more. What I'm wondering, in your experience, you opened today's content with slides on this, what this experience is doing and the collective experience we're all having with this pandemic and what issues it's bringing to our health providers related to trauma. We've had conversations actually in some similar work, and I see that Jessica highlighted those. We did a talk on working with children and adolescents recently related to telehealth. But this idea that we've kind of, as an entire nation, globally, experiences collective trauma together. And I don't know if you're having conversations about that in your context with your colleagues or not, but if you can maybe speak to that, what do you anticipate might be coming in the year, in the months, in the weeks, as we continue to endure this pandemic? What we might be learning about trauma more collectively, and how this might have impact on the types of treatments we've provided to date? I realize that's a pretty big question.
There were a few parts in that question. I'll jump in first and then let Katie and Shannon chime in. I mean, I think that there's a reason I talked about resilience. I've certainly heard quite a bit that there's going to be a tsunami or a tidal wave of mental health problems. And I do think that that is overstating it. You know, I would anticipate, oh, I'm sorry, I'll try and speak a little louder. You know, I would anticipate that we will see somewhat higher rates of depression, of grief, of generalized anxiety for people generally. But most people, I think, are actually going to get better as the stressors decrease. There is that small group that's more vulnerable and is more heavily affected. And those are the folks that I personally worry about. Often those are people who also may not have as many access to mental health resources. And so I think thinking about what are scalable interventions that we can get to those people that are affordable, that they can reach where they need it, is going to be really critical. And so I think that's the place where the field and mental health providers are going to have to get very nimble. So I hope I answered at least part of that question.
Yeah, absolutely. Katie or Shannon, any last thoughts?
I guess the main thing I would say is, you know, to some extent, telehealth has been, you know, some systems were a little bit more set up for telehealth than others when this all got started, but people are learning really quickly as they go. And I think there have been some really nice upsides to using telehealth. There are a lot of potential benefits. Like you can actually sometimes see somebody real time interact with a family member, and it gives you new information. Or I had somebody say, you know, I kept giving this person mindfulness exercises to do, and they weren't doing them, and it was frustrating to me, and I couldn't figure out why. And then we started doing telehealth, and I saw what their home environment was like, and they can't find a quiet place to close their eyes for 2 minutes, you know. So it can give us a lot of information. So I would just say, you know, the more we can kind of embrace the challenges and the opportunities, and share what we're learning as we go. I think that there are some real positives in terms of access, and that the more we can kind of think, how can I do this, instead of like, I can't possibly do this, will help us reach our clients who are often isolated and in pretty stressful situations at home and really need the help around the trauma. So I guess I would just encourage people, don't hold back on providing the treatment because people are at home. It might be when they need it the most. It might be a time when they're actually most able to engage in it. And so, you know, we want to find the most creative and effective ways to get people treatment right when they need it, rather than waiting, because we don't know how long we'll be waiting. So I think that would be one of my take homes from this.
I'd say let your clients surprise you, and collaborative decision making is really key. Sometimes we may think something that it's not a good fit or not the right time, and our clients surprise us. And so they're the experts on their experience, and we're going to be the experts on how to engage them in treatment. Thank you, guys.
Well, you hit on some great points that are perfect for us to end on, and that the point of this series that we've been doing is all about clinical innovations. And in the midst of this challenge, how we can innovate our practice, how we can learn together with our clients and our families, and how best to be able to reach them in their time of need. And so we thank you again for our panelists for serving today, as well as our participants for your questions. This does wrap up our series on clinical innovations in telehealth. We want to make sure that you're aware that all of these resources, we will be sending them out to you. For those who have registered today, you will get a list of the slides, you will get a list of resources and frequently asked questions from today. But you can also access all of the content related to this series and the others that have been conducted our School Mental Health series, and our initial series on Telehealth Tuesdays from our telehealth landing page at the MHTTC network. There's a lot of great resources there for you to access. So again, we want to thank you all for your participation today. We do ask that as you lead this session, that you please take a moment to give us your feedback. It's critically important to us to know how we're doing in terms of providing these services, but also to sustaining our funding. So please take a few moments to answer some brief questions to let us know about the training content. And again, we thank you for your participation, and we wish you all health and safety. Thank you.